Conference is being recorded. At this time, I would like to turn the conference over to Mr. Mark Waxman. Please go ahead, sir.
Thank you very much, and welcome everybody to our conference with respect to preserving hospital independence. Anyone who reads modern healthcare knows that there's a big push going on for people to merge, consolidate, affiliate. It's a rare day, I think, where management and board members of healthcare institutions don't wake up or go to sleep thinking about, who can I merge with, who can I consolidate with, what can I do to affiliate. But I think the reality is not everyone can merge, consolidate, and affiliate, but everyone still needs to survive. And for many people, engaging in those types of activities isn't really going to be their answer with respect to the future. Today, and through the course of our programs on this topic, we're going to explore, what are the circumstances that should be evaluated in looking at that question, and under what circumstances does it really make the most sense to simply preserve your independence for the best of the community, the best of your mission, and to be able to serve overall the population that is your target. Today on our panel, we have three speakers joining me, Steve Messenger, Kurt Senkel, and Ted Schwab, who I'll introduce all three in a moment, to talk about this question. And as we think about, how this actually looks, let me first remind everybody that today's program will run for an hour and a half. We will apply for 1.5 general CLE credits for the program. All New York, New Jersey, and Kansas attendees applying for CLE credit are going to have to fill out an attorney affirmation form and write down the course codes that will be announced at some time during the webcast. The attorney affirmation form and today's slides can be obtained in the handout section of your screen. Questions can be submitted during the web conference by entering them in the Q&A box. And I've told everybody that we want to make sure we reserve time for questions at the end, as well as discussion. So we hope to move forward in a timely fashion and so forth. Let me just start with an overview. Why not merge or consolidate? Our speakers are going to address, how you position yourself for success if you don't. But I just wanted, as part of an overview, to provide a number of reasons that people don't merge and consolidate. And they come from sort of experience in terms of people that have tried it and didn't work, people that thought it through and said, not for me, or a number of other reasons. And what I've listed here are some of those other reasons, one way or the other. The first, antitrust. This is not a program about antitrust, but sometimes that next merger, next consolidation is simply going to be too much. And we've seen that horizontally up in the Commonwealth, where I sit. The Partners and South Shore merger is currently under review and attack by the regulators, who said, in essence, it's just too much. We just don't see the justification. That's ongoing, and we don't know where that will end up. But, at one point, regulators just say that's too much. We've seen it in the St. Luke's, out in Idaho, where they attempted to acquire a large physician group, and again, people looked at that and said, no, it's just too much market power, not going to work. So at some points, you just can't merge and consolidate your way to, complete control of a market, complex question, but antitrust can be an issue that says this is why we're not going to do it. Other reasons are cultural issues. We've seen situations where, across medical staffs, if you attempt to integrate them, you're in for a hard slog. It may not be worth it. And there may be a variety of cultural issues across the medical staffs that might be involved at the hospital level or between a hospital and subacute or other types of relationships where, for a variety of reasons, it just isn't going to be a good mix. Other situations exist where a transaction would be too financially dilutive. You have a strong partner and a weak partner. The weak partner says, the reason we need to do this is I need capital, I don't have cash. Net result might be a lowering of the bond ratings or challenges on the financial front, and it isn't going to work for either partner to get what they need out of the relationship. That has both prevented mergers, but we've also seen where that has led to decoupling, where those who merged found out that the capital that they hoped would be there, it turns out wasn't going to be there. And that may come up when you see situations, for example, where you have urban medical centers with suburban centers, and they're trying to figure out the way to make it work, and it's just too financially dilutive to ultimately be successful. The other is when people try to merge and integrate, they want to realize the synergies or other similar buzzwords in order to save costs and lower their overall platform costs in order to be more efficient, i.e. charge less money or have lower costs so they can charge less money. Sometimes it's just not going to work. The costs of putting together two computer systems that just don't mesh are going to be very difficult. It just may be that the cost synergies that you hope to achieve, given the costs of integration and the challenges of integration, just might be too great. It may be that if you're pursuing population health, it may be that the populations don't mesh, and it's just not going to be able to do managed care contracting on a platform where you can blend a pure Medicaid base with a pure commercial base in any way that population health is really going to make sense. It may be that you can seek to realize on other types of affiliation activities that some of our speakers will talk about, but merger or outright financial consolidation in some other way, joint venture, et cetera, just isn't going to be viable because of the disparate patient bases. There are situations where people just don't like each other. The history of the organizations is such that they're just not going to be able to work well together. On paper, it works great, but when it comes to determine who's going to be the CEO, are the cultures really going to mesh? People might say, we just have different models. Not going to work. We may have just seen that again up in our area where there was a planned large merger, and after a lot of time and effort, people just said, we're just two different organizations. We're just not sure who should be running the combined organization. It's just not going to work. And if that's going to happen, you're a lot better off finding that out before you merge than finding that out afterward. So those are all the reasons why one might sort of structurally not merge, or that may come up to prevent a consolidation within a single system. Let me now introduce our speakers who will talk about what you can do if you're going to stay in that kind of setting. We're going to start with Steve Messenger, a principal and the managing partner of ECG Management. Steve has looked at these organizations on a nationwide basis, principally from the provider side, and he's going to provide some insight to that. Kurt Stenkel, President, CEO, Floyd Medical Center. He's been there since 1996, run a successful independent operation. Will tell us on the ground, how do you do that day to day, year to year, so that you can have a successful system without joining somebody else. And then Ted Schwab, partner Oliver Wyman, made sure to mention that he's actually on the beach at the moment during the course of this presentation, and we all should be jealous. Ted's a long-time experience in the healthcare field, served as the Chief Innovation Officer for a number of years for a large system in the Midwest, and will tell us how they looked at it and how one might look at it from the payer side of the equation. With that, let me turn it over to you, Steve.
Thanks, Mark. I appreciate you having me today, and thanks everybody for joining. And what I'm going to take you through is a relatively quick discussion on what we see being some of the primary drivers when we talk with CEOs across the United States. What are the primary drivers of consolidation? And do a little bit of sort of a deeper dive on each of the different areas to try to point out perhaps some alternatives to consolidation. And I think that one of the things, Mark, you had pointed out at the beginning is that if anybody reads Modern Healthcare, there seems to be a rash of conventional wisdom that suggests that hospitals need scale to survive. And several years ago, I think the conventional wisdom was that in order to survive as an independent organization or survive as an organization, you were going to have to be part of a delivery system that had $1 to $2 billion in revenue. And over time, that number has grown to where we are hearing some experts suggest that in order to be an organization that is going to prevail in your market, you need to be able to think about in the $6 to $10 billion of revenue range to be able to really prevail in sort of the post-reform economy. And I think that one of the things that we see organizations doing is looking at a M&A activity as their primary strategy instead of one of many different tactics that they could pursue in light of something that would help them position themselves in the market not only for the near term, but for the long term. So when you think about some of the things that we hear in terms of capital availability, there clearly is a sense, and I think the data would suggest that larger consolidated systems, they have better bond rating, they have better credit worthiness, they have cheaper access to capital, and they typically deploy more capital. So we absolutely see evidence to the fact that larger organizations with more revenue and bigger balance sheets have better capital availability. The other thing that we hear quite a bit of is that organizations in consolidated systems typically experience a reduction in their overhead costs. And they can clearly take advantage of supply chain savings and labor costs as well in a consolidated system. The other thing I think that we hear quite often is that organizations, hospital systems that are looking at trying to take risk with health plans, taking risk-based contracts, they need to have a tremendous amount of capital availability and a tremendous balance sheet strength to weather the storms of adverse selection risk. The other thing that we hear quite often is that in order to prevail in a post-reform world, we're going to need to invest in the data analytics and the population health management infrastructure that is going to allow us to really make this transition from fee-for-service medicine to something that's more value-based. And so the investment in the data warehouses, in the analytic, in the software, as well as the competencies and the people, the resources, really requires a tremendous amount of scale, and so therefore merging allows us to aggregate those dollars to pool our investment. And then one of the other elements that we hear quite a bit is that we gain an incredible amount of market coverage where we can not only expand our clinical reach, but expand our geographic reach and broaden the base of covered lives if we think about expanding our geographic footprint through some sort of a merger or consolidation. So what I'd like to do on the next several slides is talk a little bit about some arguments, I guess, if you will, to the whole elements of some of the drivers of consolidation. And the first one I want to talk about is capital availability, because clearly I think that capital availability is absolutely impacted by the larger the organization is, the more days cash on hand, the larger the balance sheet. We typically find that bond ratings favor those organizations that are much larger and have economic scale. The dilemma with that argument in today's interest rate climate is that we typically see that among investment grade credits that the rates are suppressed. And I remember talking with a friend of mine, a CEO of a 100-bed hospital in Maryland, who went to market the same week that Johns Hopkins went to market with an offering. And he said, boy, these guys are unbelievable in terms of their size, their credit rating. They really did very, very well. But when we look at the spread, our offering was only 17 basis points more expensive than theirs was. And so you have a 100-bed hospital, going to market at the same time that Johns Hopkins is, and looking at the spread as being really not that different. And so when you think about the effect of consolidating to get better access to credit and seeking a better bond rating in this current interest rate environment, you might not actually get the return that you're looking for based on the activity. The other thing, as Mark pointed out, is that often one of the reasons why large consolidating organizations spend more capital is they're spending the capital to actually accomplish the integration. And so sometimes we see that organizations are integrating and consolidating their way into a very, very unhealthy balance sheet where they have very little capital availability for anything other than aggregation, and they don't have any reserves to help with other market development activities or opportunities that might present themselves. So the next thing I wanted to spend a little bit of time on is talking about overhead, because we have worked with many organizations that when they are thinking about their options and they present a consolidating financial statement, they'll make some assumptions about, well, we could save 4% on the sell side and 4% on the buy side for a total, combined aggregated cost savings of something that is very, very attractive. And it could be, millions and millions of dollars that really are going to flow to the bottom line and impact cash flow in a very positive way. And over the course of the last several years, we have looked at ECG. We have looked at every single study that has come out that evaluates post-merger integration activity and success and economics of that. And there are 9 articles, 9 scholarly articles that have been published that have really tried to address quite a bit of the cost savings issues that we see that are projected with hospital consolidation. And there's a couple of interesting threads to that. And one of them is that, there's a conventional wisdom that if we combine our organizations, what we're going to be able to do is do things like combine our business offices and combine our overhead structure such that we're going to see incredible efficiencies out of that. And one of the things that we see is that hospitals that are of a size with approximately 10,000 or more admissions, they typically are about as efficient as they're going to be as it relates to things like business office. And so we might be able to wring out some cost savings on a basis of some basis points, if you will. But in terms of major cost savings that would really drive, millions of dollars of cost savings, we just don't see it. And so there's this, I think, a rule of thumb that we are seeing in the analytics that we do is that if you have more than 10,000 admissions, you probably are as about efficient as you're going to get, and the efficiencies might be sort of very, very incremental, but not incredibly dramatic when we think about consolidating organizations of 10,000 admissions or more. The other thing that we see is that one of the major drivers of savings upon consolidation is actually rationalization of a market. So in a very typical community example, we have 2 community hospitals, they merge together and they build a replacement facility, or they make decisions to say, let's not have 2 heart programs, 2 rehab programs, let's actually consolidate those services on one campus or the other. And we see that actually drives a very significant amount of savings. The dilemma with that is that is an incredibly hard thing to do unless we are going to tear out 2 hospitals and replace it with a unified hospital. We've worked with a number of organizations that have tried to rationalize and consolidate clinical services, and it is incredibly difficult because you have medical staff issues of physicians at Hospital A don't want to close down open heart services, even though they might be doing 50 cases, because they're nervous about what impact that's going to have on their referral business as they think about what my cardiology portfolio might be. We have hospitals that have boards that have donated, and a donor community is saying, I don't want you to tear down my hospital or close or diminish services at the hospital that I've been donating years and years and years to. So we see that that even though the consolidation of clinical services drives savings, we see very little evidence that hospitals are actually able to pull off rationalization of services. The other thing that we see is that on sort of the non-labor supply chain side, and Mark could probably give you a lot more detail on this than I can, but there are many legal structures and collaborative arrangements that we see organizations participating with where they, in essence, are pooling their resources around group purchasing. And so in the market where I live in Northern Virginia, you have MedStar, Novant, and Centera that have formed a collaborative where they are actually making joint purchasing decisions on everything from implantable devices to IT and other technologies and other large diagnostic pieces of equipment. And so we are seeing that you can accomplish the kinds of supply chain savings by looking at some of these purchasing collaboratives as a substitute for consolidation. The other one that I wanted to spend a little bit of time on is risk, because we hear a lot of organizations saying, boy, as I think about migrating from fee-for-service to shared savings to something that looks more like capitation or one of those risk-based kinds of payment systems, I need to protect myself because I might have some adverse selection. And I think that one of the things that we are seeing is that most hospitals should never be in the business of taking adverse selection risk. That's really what the insurance organizations do. And so therefore you see their strategies around how do they guard against taking adverse selection by having larger and larger population sizes. But really the risk that's appropriate for a hospital to think of is the risk associated with patient management. And that is, I need to identify, as a health system, I need to identify those patients that are going to be the highest utilizers of healthcare services, and I need to build in care management, patient navigation pathways so that I can effectively manage that patient experience, so that I can protect myself against any adverse selection, and I'm really focused on the risk of patient management. Indeed, we see organizations that are looking at how do we go after the most expensive, the highest risk patient, because if we manage them very effectively, we might do very, very well on a subcap type of an arrangement. So thinking about the risk of adverse selection, which is insurance risk, versus the risk of patient management, which is really the risk that a hospital health system can manage, is really, I think, a little bit more appropriate to think about the kind of scale you're going to need for patient management, managing patient management risk. The next piece is the data analytics and the population health management infrastructure. And I think that one of the things that we are seeing is that, not only is there an article in Modern Healthcare every week about organizations that are thinking about consolidation, but we are peppered with conference mailings and articles around the infrastructure needed for population and health management and the data analytics platform and the investments required to, buy these large pieces of, software hardware to help us with the data warehouses and the analytics pieces. And I think that one of the things that we try to take a very critical look at is an organization's ability to actually take advantage of building a data warehouse and the population health infrastructure. Because one of the things that we're finding is that we can do very effective clinical targeting by looking at a claims run of a defined population, say our employees, and applying a spreadsheet jockey to taking a look at that. We can do very effective clinical targeting around identifying what are those high-cost areas that we really need to be focused on for patient management. And so what we are trying to urge organizations to think about is, can I delay the investment in my data analytics package to tomorrow or the next day when I'm really going to be in a position where I can take advantage of the advanced analytic functionality that many of these systems offer, and perhaps at that point when I'm really ready to make that investment, where I'm really, my organization is poised to take advantage and we're really invested in population health management and have the physicians lined up for that, then I'm going to be in a position where perhaps we are going to be able to get more value out of systems that have a couple of years to mature. The other thing I think that's important to understand is that when you look at some of these large contracting organizations, and Mark Waxman just said, he's up in the Boston area, if you look at some of the large network arrangements in the New England marketplace, Partners, Nequa, and the variety of others, what they've done very effectively is say, we are going to, at that network level, at that contracting network level, we're going to be investing in some of the data analytics competencies, and you bring your integrated system and you nest it within our contracting network, and we'll provide you access to those data analytics competencies and capabilities to actually help you manage care in your local market. You just make sure that you have aligned physicians and you have the care management processes in place so that as we start sharing clinical information with you, you're in a position to actually utilize it in a way that is going to drive out utilization and allow you all to make decisions that are going to affect us in terms of our underlying contracts. So we see organizations delaying expenditure in this because for a variety of reasons, as well as organizations saying in a network arrangement, maybe I can get access to this so I don't have to incur the entirety of the investment on my own. And then the last piece of this in terms of market coverage, which gets into really the next conversation I wanted to have is that we see organizations, competitive organizations, coming together to say, we realize that we are never going to outcompete each other in terms of our clinical services. What we really need to do is think about how we might come together so that we can not only create this investment vehicle where we can pool our resources to build the data analytics platform, but we're going to have broader market coverage if we come together in a contractual arrangement where we can be clinically and perhaps financially integrated and then go shoulder to shoulder to the health systems and negotiate with them for contracts that allow us for shared savings. And so we're seeing a number of collaborative organizations around the United States start to pop up that are really focused on how do we as competitive hospitals come together so that we can contract en masse in a mutually beneficial way in partnership, and do that with the health plans where we can actually do a better job in terms of looking at how we negotiate a risk-based or a shared savings-based kind of arrangement. And I think that the other thing that we are seeing, and we certainly see it on the physician side, is that one of the dilemmas of consolidation and one of the dilemmas of M&A activity is that the aggregation phase of an organization, organizations that are saying we're going to have to grow by M&A, takes a tremendous toll on an organization's ability to innovate and to perform. And so we see this in the physician side, where organizations through this aggregation phase of accumulating physicians into an employed model, and then they wake up and they say, we now have got to start to innovate and perform because we can't suffer through the losses of poor performance. So we actually now have to worry about performance. And we see actually that in organizations across the United States that are focused on M&A as a primary strategy, we are seeing them fall behind innovation in terms of population health management, rationalizing of care in the marketplace than some of their competitors. And we actually are seeing talent flight out of organizations that are really focused on M&A to other organizations, because trying to integrate two very large organizations, and Mark pointed out a lot of the cultural issues that result, creates a toll on an organization in terms of their ability to innovate and stay market leading. So if you're going to participate in a consolidation, you have to be very careful about, do we actually have the resources to pull it off in a time where we have to be thinking very innovatively about what's happening in our market and how do we continue to respond. And what I want to do is finish up and then turn it over to Kurt to walk you through some of his experiences at Floyd, is talk a little bit about this concept of a clinically integrated network, and just give you one example of an organization that we're working with, and there are many, many other examples, but this is an organization in the Midwest. There are 9 independent hospitals, and they came together and they said, we have a large competitor in our market that is very acquisitive, and we're nervous that if one of the 9 or 2 of the 9 listen to the siren song and join this much larger, very acquisitive organization, it's going to start a cascading effect where we're all going to start to have to think about consolidation, because our boards are looking at us saying, everybody else is doing this. We're reading this in Modern Healthcare. Are we not being responsible by not taking this step? And so one of the things they said is, as opposed to the trajectory of consolidation, let's think about a world where our trajectory of remaining independent is going to be based on our ability to create network relationships where we can pool some of our resources, invest in those competencies that we think are going to allow us to innovate much, much faster than the market is going to require, and positions us well in the future. And so in this example, we have 9 hospitals that created this regional network in the blue box, in the blue rectangle, where they basically said, let's get together, let's take a look at consolidating claims data from all of our employee health plans and look at some analytics where we can decide what are the targets of opportunity that we want to focus on that are those high-cost areas, whether it's low back pain or congestive heart failure or people with behavioral health issues or the like. This group of organizations picked 1 or 2 of those clinical targets and said, let's actually create a organizational infrastructure where we can become clinically integrated and attack 1 or 2 of those disease states and come up with a protocol that we're going to spread across each 9 of our organizations, where we can do things like treat congestive heart failure, low back pain, whatever the case might be, in a manner that's common, where we can test the results and see what the cost savings would be, and actually start to baby step our way through a clinical integration development process. At the same time, one of the things they said, in our market we have organizations that started this a long time ago. They have a Medicare shared savings accountable care organization. They're taking risk contracts. So not only are they clinically integrated because they're doing things with clinical protocols, but they're also financially integrated because they're taking risks together. And so let's basically pool our resources and buy service from this ACO organization, which is the organization in the green on the left-hand side, where we are going to buy services from them to help us build our competencies around population health management so that we don't have to go it alone in terms of investment not only in the hardware pieces, but actually the expertise to help drive through innovation in our market. And so whether you're in the Philadelphia market and you're looking at Noble or Allspire organizations that are coming together, these large health systems that are coming together to form these contracting networks, or in markets in the Midwest where we are with this organization, or in Kurt's market where he's doing the same, we are seeing that there are many substitutes to consolidation that perhaps allow you to accomplish a lot of your strategic initiatives without actually having to say, boy, we have to stop and actually think about consolidating our organization to another because we just don't have the wherewithal to make it work. So I tried to paint a picture of a couple of alternatives that organizations can pursue when they think about their future and how they can prevail in this post-reform economy. And let me turn it over to Kurt, and he can walk you through a case study of his organization and tell you a little bit about how his organization is approaching this whole concept of independence and how they're working through that.
Well, thank you, Steve. I appreciate the opportunity to participate in this webinar. We're located in the northwest corner of Georgia, and you can see on the map, this is not the far northwest corner of Georgia, but almost. And as I begin to describe Floyd and our case in point, as Steve put it, as I was thinking about this, I got to thinking about my high school basketball days. I always wanted to be a better athlete than I was. Still the case. And way back then when I was playing high school basketball in the 1970s, I wanted to be the type of player that Magic Johnson or Larry Bird or Michael Jordan, for that matter, were. The player that would just dominate the game by his scoring, his passing, his rebounding, his defense. And as much as I wanted to be that kind of player, I just didn't have the athletic ability to be that kind of player. Few are. And as you look at modern healthcare predicting these huge mega systems and everybody else in the popular health press, the numbers of mega systems that are going to run things in the United States, well, for us here at Floyd Medical Center in the northwest corner of Georgia, back to my basketball analogy, as much as I wanted to be Magic Johnson, Larry Bird, Michael Jordan, I just didn't have the capability to be that. And what I ended up being in my basketball career was a pretty good 6-foot-tall point guard. And we had a good team around us, and we competed my junior and senior year for the state championship. Got pretty far in the state playoffs. And so I kind of look at that analogy as being apropos of my health system as well. We are not going to be the integrator of care to get $6 billion, with a capital B, to be one of these mega systems. It'd take a heck of a long time to grow to that. We're locally owned. We originated way back in 1942, as you can see on this slide. I won't read through all the bullet points. We've done a pretty good job taking care of our community. We are about $330 million in net revenue. We just recently acquired a critical access hospital to the south of us, which was a big victory for us. We've got a big primary care network. We've done a pretty good job in this fee-for-service environment. If you look at the next slide, we've done a lot of things that a lot of community hospitals have done. We've focused on things that we do well. We've created centers of excellence. We've won a good bit of market share in our region. We have competed for years with a successful HCA hospital that historically has been on the top 10 list for HCA in their system. I think we've knocked them off of that list because we have just tended to our knitting here. The old tale of the tortoise and the hare, while HCA has focused on short-term earnings and their LBOs and going public, going private, we have just slow and steady wins the race, and we have won a heck of a lot of market share through the years. So as we've played the fee-for-service game, we've done pretty well. And I just flipped the slides to show you our payer mix. We have a challenging payer mix, and I know there are those that have a better payer mix, those that have a worse payer mix. But you can see our uninsured is over 10%. Our Medicare about 38%. Our Medicaid running about 19%. Just like anybody else, we make it or break it on our ability to manage our commercial. And as you look in Georgia, among larger hospitals, we're in the top 4 or 5 in terms of our unreimbursed costs. We get you have to play with the numbers, but we do a calculation every year to see where we rank on our unreimbursed costs in the state of Georgia, utilizing the disproportionate share Indigent Care Trust Fund methodology that's utilized in Georgia, and we're always in the top 5 or 6 in terms of our unreimbursed costs on that disproportionate share methodology. So part of our success in being successful financially, and again we have been fairly successful financially in this fee-for-service agenda, is that we have employed for the last 8 years a Lean Six Sigma methodology. And we have been working through what we call a 120-day workout. It's a twist on the General Electric 100-day workout, where we're always working on something to improve our margin through cost reduction initiatives, through revenue enhancement initiatives. We put them in 120-day workout methodology where all of our managers are working systematically with check-ins to make sure we're moving the ball forward. And we've cataloged over $50 million worth of changes, improvements in our margin over the last 8 years, utilizing our Lean Six Sigma methodology and our 120-day workout. And so we've been doing fairly well given the cards that we were given to play with through the years, but the environment's changing. We all know that the fee-for-service environment is changing, so what does the future hold for Floyd? That was my last slide. But I want to now address that. This webinar is entitled Pursuing Independence. Well, what does that mean? I mean, what does independence mean? Will there be standalone hospitals as we move down this road of health reform? We know what's all in the popular press, although I've been hearing that the future of the standalone hospital is dim ever since I've been in healthcare. But maybe we are in a different environment now. If we're remaining in fee-for-service as the rules have been written for all these years, I feel pretty good about all of our strategies. But right now, my biggest worry, as I sit and look at my system that I am managing, is what about narrow networks? What about getting cut out? Is my system indispensable for area payers? As people get region-wide contracts, can they do without us? That's my biggest worry. My biggest worry is not how do I handle cuts in reimbursement, how do I handle the future payment methodologies. I think, and I feel pretty confident that we've got the ability and the alacrity to move with that. As Steve just talked about, all of the ways that systems have worked to reduce overhead. I mean, we're in a major supply chain cooperative that gets us some of the best pricing you can find anywhere. Through our Lean Six Sigma methodologies, we're always finding cheaper ways to do things. And, well, this will be music to the other presenters on the phone call's ears. I mean, you use good consultants. They help you find other savings you might have thought of as well. And as it pertains to capital access, we are quasi-governmental. We have our local county government. I think as long as we are operationally and financially successful, we've got some county government backing of our bonds. So that gets us access to the markets, and sometimes at favorable interest rates. So while that's a concern, I don't think it's necessarily the major concern. Again, my biggest worry is narrow networks, being cut out. Is my system indispensable? And right now, we have some measure of indispensability, but not as much as I want. And so what I am busy about doing now is trying to get a higher level of being indispensable. We're working with 3 other hospitals along what I call the west coast of Georgia. So you look at the middle of Georgia and go all the way up to the line. We have 4 systems that are working together in an alliance. West Georgia Medical Center in LaGrange, Georgia, the Tanner Medical System in Carrollton, Floyd Medical Center in Rome, and then north of us, Hamilton Medical Center in Dalton. Altogether, we cover about $1 billion in population, and we'd have combined revenues of about $1 billion. We're not merging. We have a loose alliance where we're trying to figure out those operational and financial savings that we can jointly find, and we're also pursuing clinical integration with the goal in mind that at some point in the not-too-distant future, we could jointly contract according to Federal Trade Commission rules. So that's one thing that we are actively pursuing is clinical integration, preserving our operational and governance independence, but then working together on a regional basis towards clinical integration and towards those areas where we can financially and operationally integrate to save money. If we don't do this type of activity, I think there really is a risk of being cut out. As Blue Cross and United and other payers look around, I mean, if we don't dance to their reimbursement tune, we could legitimately be cut out because we have providers all around us. So for me, that's my biggest worry, and I would venture to say it should be a worry for a lot of independent hospitals. Now, if you're in the middle of a geographic area where there's not another provider for 100 miles, maybe you already are indispensable just because of your geographic situation. But if you're not, if you have other providers around you, I think that's a risk for any independent facility. And I guess perhaps the last thing I want to say as it relates to independence and what this means, I think it may mean a voice in governance. Independence meaning you're all by yourself. You get to make your own calls on everything. You have the sole decision-making ability. As you start to do the type of network investigation, affiliations that we're doing, you start to give up some decision-making as you move into shared decision-making. And I think that's something you have to be willing to do and willing to consider for the larger aim. And again, for me, the larger aim is to be a part of something whereby we're indispensable, that no payer in our region can do without us. Why is that important? Certainly because I run my organization and I want to see it survive, but the mission of our organization, I mean, we're a not-for-profit organization. We were founded in 1942 to care for our community. Georgia is a blue state. There's no Medicaid expansion on the horizon. We're going to have, just as Jesus said in the gospel, the poor will always be with you. Well, we're going to have the indigent in our facility. Somehow they're going to have to be taken care of. I see this as a mission priority. If we're going to continue our mission, we've got to pursue indispensability. And for me, that means a larger footprint. And so what I want to try to achieve is that larger footprint with a voice in the governance of that system, and understanding I have to perhaps give up some flexibility, but my ultimate goal is to be able to maintain a strong voice in the ultimate governance. So with that, I'll pass it on to the next speaker.
Thanks. This is Mark. Let me just interject for a moment. For those of you looking for codes, I want to announce the code 6ZPP. Just to repeat that, 6ZPP for those in states that need a code at this point. With that, let's move on to Ted.
Hey, thanks, Mark. And, Christina, the screen is not moving for me, and so I might have to turn that over to you at this point. A little bit of technical difficulties there. But, I want to build on the last speaker and indispensability. So in my practice, I've worked with payers all over the country. Some of the largest Blue Cross Blue Shields, probably a third of those around the country, and then all of the major payers. And there are really three things that I want you to know as we start this. Is number one, it is all about the network. It is all about indispensability. And from my large payers, it doesn't necessarily mean that bigger is better. Number two is that the payers are just as confused about what's going to happen next as you may be. There's a belief out there that there is a secret sauce that insurance companies own, that the payer community has this figured out, and nothing could be further from the truth. So that gives you an incredible opportunity to begin having those conversations. The third thing, and again, I love the conversation that we just had with the Floyd Medical Center and the good folks from Floyd, because you got to have the docs. If there is a thought out there that part of remaining independent is to remain independent of the physicians, that's just not a strategy from the payer point of view that's going to work. And Christina, I'm now on slide 16. And when we think about the independent community hospitals choices, there are really four things come to mind. And I think I just mentioned some of those. Number one is the health plan partnership. And I want to underline the word partnership in there. We're seeing just an enormous amount of product development. And again, it's not all with the large monolithic systems out there. The amount of product development we're seeing in this second tier with independent hospitals, independent systems, and small community-based systems is pretty staggering. So the first piece of advice out of my 20 minutes is to begin having the conversations and educate yourselves about those second-tier products. The second thing is the physician organization partnerships. I've got a slide on here about some things to consider later on. The third thing, and I don't know how much information out there is about the private exchanges. The public exchanges get all of the popular press, and whether the number is 7 million or the number is 8 million. But what is not getting press out there are the private exchanges, those being run by Buck, those being run by Mercer, those being run by Aon, that are partnering with the big payers and creating micro networks. And what they're doing is they are the go-between between small businesses, that's who's on the private exchanges, and very local markets. So my third piece of advice is to begin educating yourselves about the private exchanges and what is happening in the small businesses. I can't really go on without talking about health systems affiliation. More and more and more, and I know Steve talked earlier on about the big amalgamations we're seeing and the big consolidations. We're beginning to see a trend away from that and more towards affiliations, just because the cost of the mergers and the fruits of acquisitions just haven't borne out. Christine, I'm now on slide 17. So think of 5 things that help you survive in this world. Number one, and I'll talk a bit about embracing value-based contracting. It's not the old days of financial risk that we saw in the 1990s. It's very different. The second thing is aligning with physicians around these networks and around these micro networks in order to contract. Bundled payments, whether you like bundled payments or not. That is the emerging trend for smaller community hospitals that we're seeing all over the country. It's easier for health systems for payers to administer. It's easier for small businesses to understand, and the ones that we're seeing out there being developed in smaller systems are mainly around orthopedic care, but we're beginning to see it around cardiovascular care and even some medical bundles around 60-day post-acute. The fourth thing is microcontracting, and I'll get into that a little bit. And innovation. I really like that slide that the last speaker put up about the things that they do well, where they are the number one, where they're the leader in their markets, where they're in the number one position. And you think from an insurance company's point of view about indispensability, if you are the leading stroke program in your community, I as an insurance company, I've got to have a stroke program. If you are the number one provider of emergency services, I've got to have an emergency room. If you're the number one provider of post-acute care, I've got to have post-acute care. So it's getting to that number one or number two position in those very select areas and then using that as a footprint to contract on a larger basis. But when we talk about mission, the things that are on payers' minds these days range from everything from clinical care to telehealth and everything in between. Christine, I'm on to the next slide about budgeted care. So when we talk about value-based care and value-based contracting from an insurance perspective, from a payer perspective, it's about a budget. And when you think of your Medicare contracting, even if that's through a Medicare Advantage program, if you think about contracting and having that conversation through Medicaid managed care, it is about how do you manage a budget. I did hear Steve very early on talking about some really significant and sizable investments in value-based care, population health management. I think that there is another way to get into that game, especially if you are a geographically contained community hospital, and it is to focus on three things. One is very simple data analytics, and a lot of the payers are offering those products. They're not very good, but the cost of that has come way down. The second thing is very simple, very direct care management. If you think of population sizes of just 100 to 150,000, the number of people who really need to be managed in that population are somewhere around 5,000. And if you do the numbers, that can be done with 4 to 5 care managers. And so I don't worry so much about the investment in care management as I do the people who are doing that. When you think about when you need to be ready for budgeted care management, for budgeted care and care management, right now all of the insurance companies are focusing on January 1st, 2017. What happens on January 1st, 2017? That is when the small business public exchanges are supposed to open, and I'm not going to forecast whether or not they'll be pushed back again. But assuming that happens, the private exchanges are also getting ready for that date, and it's the movement of those 20 to 25 million folks as they expect in the small businesses. And being in the independent community hospital business, it is the small and medium-sized businesses where you have contracting capabilities. Christine, I'm on the next slide, which is slide 19, and aligning with physicians around micro networks. I've put in here a roadmap that we frequently use around provider alignment. And one of the things that I hear in my conversations on both sides is how doggone expensive it is for a community hospital to go and employ physicians. But what I want to talk about today very quickly is that it is about the network. It doesn't mean you have to own folks. It is about the depth and the breadth of the network and becoming indispensable in those narrow networks. And so you've got to have that alignment, whether it's through your PHO, whether it's through an ACO, whether it's through an IPA, whether through its joint ventures and employment model, think of those as vehicles and mechanisms and begin to think about the dots on the map and how you have enough scale and mass in that geography that you become indispensable. Christine, I'm now on to slide 20, and let's just talk about bundled payments. So we did a study about the investment or the ease of implementation and the improvement opportunity associated with different bundled payments. And to no great surprise, it comes out in surgical areas. It comes to procedural areas. We haven't seen a lot of community hospitals get into the bundled payments. It has really been the domain of the larger systems. Having said that, they haven't done that great of a job. You hear things like, oh, you know, St. Joe's down in Orange County in California. You've heard some of the things that the Cleveland Clinic has put out there. But those are massive, massive national center of excellence strategies that really don't meet local payers' needs. And if I had a dime for every time I talked about, or if I talked to a local payer or insurance company about how do I decrease or how do I increase the value or how do I decrease the cost of X. And when I'm talking about X, they think about discrete services. How do I increase the value of a hip replacement? How do I increase the value of a open heart surgery? How do I increase the value of a back surgery? How do I increase the value of general surgery? They're just beginning to think about post-acute care and bundling all of the things that go into that. It's an emerging area. But I would encourage you, when you're having these conversations with insurance companies, to begin thinking about how you can bundle, and the opportunity today is in this little area. Christine, I'm on to the next slide, which is slide 21, and emerging contracting trends. One of the things I want to impress upon folks today is that the complexity associated with your contracting and the complexity associated with contracting for a very large system are two different things. And the second thing I want to impress upon the folks on the call today is to approach this and handle it as a portfolio or a palette of care. There are some direct insurance opportunities out there that you got to think through very quickly. One of the areas that wasn't open to you before the rise of the private and public exchanges is going in and contracting directly with the insurance companies for individuals, groups of individuals. And that's what the public exchanges did. They took the individual market and allowed that to become commoditized and then begin selling those populations off to insurance companies back to providers. Heretofore, we've always seen that as a PPO product, but now that's a real product for community hospitals to think about. Medicare Advantage, I'm a big proponent. I understand the cuts that have come down from CMS. Having said that, as we all know on this phone, it is a county-by-county product. It is one of the most localized insurance products out there. I'm not encouraging folks to go out, run out and get a license, but the ability to contract with the large Medicare Advantage providers, the large Medicare Advantage payers out there. Humana, for example, contracts all over the place on a county-by-county basis. The small group and the mid-market that we talked about, is really an opportunity for 2017. In addition to contracting directly with my clients, with insurance companies, I've heard the last caller talk about the opportunities to go seek some sort of sub-arrangement. You've got to think about a larger affiliation strategy. but taking on the value-based risk for just your geography, just for your service, just for your bundle, tremendous opportunities out there. If you go all the way to the right-hand side of that particular slide, there are some emerging opportunities around selling products directly to the consumers. We're beginning to see the emergence of ancillary insurance partnerships and consumer buyouts. I wouldn't pay much attention to those today. We see those as emerging. Right now, some of the larger systems are beginning to put those products on the public exchanges, but keep an eye out for it. Christine, I'm moving to now my second to my last slide. It's talking about continuous innovation. It's real easy for folks in the consulting arena who go around the country to look at these large systems and go, oh my goodness, that's where innovation is going to come from. I don't think so. What we're seeing out there, and again, as I work on both sides of the aisle here, but when I put on my payer glasses and look at it through those lenses, the type of innovation coming up from the ground, we're seeing most of that in the smaller community-based systems. And here are things that payers are really interested in. When we talk about the situation of Floyd, we talk about areas that are more rural. Telehealth or e-health, however you want to categorize it, is a big area that they're thinking about. They're trying to figure out, how do I get care into a doctor's office, into a consumer's home that doesn't have access to a hospital? The closest hospital might be 25 miles away. How do I have that connectivity? How do I deliver care without having that patient who may be very ill having to drive 25 miles? How do I get the expertise that may be at a community-based medical center out to a critical access hospital? I was just talking to one of my clients in the US, and they've started a robotic program where they've got a robot in the emergency room in ICUs, and the robot has a face on it, but it's really a screen. It's hooked into somebody in a larger medical system, and there are doctors in a control room working the robot, doing the diagnostics, and actually prescribing care from afar. So that thing is pretty important to watch. When you think of partnering directly with businesses, small employers, medium-sized employers out there, while their cost is always in their highest 1 to 2% of spenders, they're 1 to 2% of folks who are really sick or have had train wrecks or have some sort of serious condition, the things on the top of their mind is all about wellness. And I know it doesn't make economic sense. I know they should be focused on the 1 to 2%, but believe me, into the payers out there, the insurance companies, they're all very sophisticated wellness products in place so that they can get share of consumer mind. Everybody and their brother's giving away a Fitbit. Everybody and their brother's got a new website out there. So while it might not make immediate economic sense, those are some of the things to begin to think about in innovation. And in closing, before I hand it back to Mark, and again, Mark, thanks for putting this together, and thanks for everybody who's on the phone. Remember where we started. Number one, it's all about the networks and becoming indispensable. Number two, the insurance companies are just as confused as you are and are looking for the partnerships and those conversations. And number three, and most importantly, it's about the network, and meaning about the network, you have to have that partnership with the doctors. Mark, I'm going to hand it back to you now.
Thanks very much, Ted, and thanks everybody for their comments. We're looking for, questions that folks might have of our presenters. Let me just start myself, Steve. One of the things that everyone talks about is the network and ACOs and so forth. Do you really need to plan for population health? And if you do, can you do that as a, quote, independent, or how big of an independent do you need to be in order to think you're really going to get into a population health kind of game?
Well, we have, as just an example, we're working with an organization in the Midwest. It is in a town called Champaign-Urbana. It's the Carle Clinic, Carle Health Foundation. It's an integrated organization. They have said that they want to pursue population health, and one of the things that they're taking a first stab at is thinking about how do we solve the issue of dual eligibles. And as people know, dual eligible folks are typically very, very ill, incredibly high utilizers, and they represent a real challenge in terms of patient management. And what they have done is they've taken one physician who has responsibility for a panel of 50 dual eligibles, and they're looking at a per member per month type of a premium of $6,000 to $8,000 because of how sick these folks are, and doing a very good job of really just trying to manage these folks so that they don't keep going back and forth from acute to chronic phases. They can keep them out of the hospital and manage them better. So we are seeing that organizations can take very, very small populations and do a very effective job on population health. So I think that, as Ted said, the scale of this is something that I think people have to think through to say, in a market where a lot of people reside, where there might be 100 to 200,000 folks, we can do a very good job of managing the care of that population without incredible investments in infrastructure and technology. It is really the kinds of investment we're making and saying to people, your job is to be on top and identify these sick patients and help them navigate and help them manage so that if they run out of their prescription of diuretics, they get it so that they don't wind up in the hospital a couple of weeks later with an acute episode of congestive heart failure. So there's a lot of baby stepping we can do to be very, very effective in this era of confusion of fee-for-service to fee-for-value.
Great, kind of interesting approach. Just remember, whenever you're dealing with compensation to your physicians, you got to think about the normal Stark rules and so forth. Even though you've focused on cutting costs, you still need to look at how those financial relationships work. Kurt, let me turn to you with a question about this. I'm curious, as you've kind of stayed in your market position, how has your relationship with your physician complement changed, and how have you tried to get them to look at this as being innovators and focused on how networks have to evolve in the future?
We have a pretty unique circumstance in our marketplace. We have the presence of a very large multi-specialty clinic. Our medical staff is made up of close to 300 individual doctors, and they account for half of them at the Harbin Clinic here in Rome. And if you're interested, you can Google them and see how big they are. I mean, they represent all of the specialties in town. And so when you talk about our physicians, it's not like it is in a number of communities where you may have small groups here and there. We've got this large group. That's the Harbin Clinic. And so many of our strategies have to do with how we engage them. And it's a unique dynamic. On the one hand, they bring together a wonderful array of specialties and a high degree of sophistication in their understanding of the need to do some of these things, but they are an economic entity unto themselves. And they have their own strategic plan, which is They want to be the integrator of care for the population being served here. And they want my hospital and the other hospital to be their vendors. Now, they haven't said that as baldly as I just did to me, but it is their strategy. Of course, my strategy is to work collaboratively. So, that's my challenge and that's our dance. And part of our response has been our primary care network. And you saw on my slide that we've got, close to 50 primary care docs in about 25 practice locations in our multi-county region as access points, as where the Harbin Clinic gets their referrals. So I hope you're getting a sense a little bit of what our dynamics are about. And so my task is to try to put that together and to try to put things together that make sense for the Harbin Clinic to do with us. And longer answer than you wanted. I mean, it's not a simple task given our complexities with this major player.
Well, I appreciate that, and the relationship with strong physician groups. We're seeing repeats in some respects what we saw in the 90s, and raises the question of damned if you do and damned if you don't with some of these relationships that gave rise in part to the St. Luke's desire, I think, in Idaho to acquire one of the big physician players in town, and they ended up a little bit in the soup. So that certainly is an issue.
Right.
Ted?
Yeah, we'd love for them to join with us, but right now they are doing so well with their strategies that they don't see a burning platform yet. So there's a lot for us to talk about as time goes on.
Interesting competitive dynamics.
Mm-hmm.
Right. Ted, one of the things that you did mention and people are looking at is changing the relationship with the health plans to, let's partner together with respect to product development, market development. If I'm the number 2 player in town or number 3 in the market, and the number 1 player has kind of locked up the strong relationship with the big plan, maybe the number 2 plan will come to me and say, can we work together to compete collectively against those other guys? What kind of advice do you give people about beginning to negotiate with each other about joint product development? What is it you start talking about? Ted, we got you?
I'm not sure he's still on as I look at the presenters list.
All right. Well, Steve, you want to take that one?
Yes, absolutely. And I think that one of the things that we see as something that fosters the development of these partnership arrangements, these network arrangements, and I would agree with Ted that everything is about the network and the relationship that organizations have with you have with the physicians, especially primary care physicians. But one of the things that we see happening in markets is there's typically some sort of a sentinel event, whether it's in the example I gave, we have a large competitor coming in and making incursions into the market that sort of takes all these independents and they start to get together to say, what are we going to do together that is going to forestall this growth of this juggernaut, to organizations reacting to a Blue Cross or an Aetna or a large payer aligning very closely and offering a narrow network product with a competitor. We see that those kinds of events typically cause this, this competitive response, which is let's get together, not merge, but how are we going to think about the insurance organization really as our primary, more effective competitor than us trying to, kick each other under the table in terms of trying to steal some market share points on cardiology or orthopedics. And so we actually see that those conversations are happening in markets where we have not only a common threat, but we also have a common insurer. So in the Philadelphia market, for example, Philadelphia borders, New Jersey, what we're finding is that the organizations that are in Pennsylvania and New Jersey, north of Philadelphia, where Independence, Blue Cross, and Aetna are not strong, have a very natural alliance because they can get together and they say, we all contract with the same health plan, and so therefore, when we go to that health plan, we are going to have a better conversation because we understand them and we're negotiating over a base of covered lives that is in common with each other. They're all insured by the same plans. in the Philadelphia market, people are coming together because they're saying, we want to come together and look at a relationship with Blue Cross where we can perhaps be in their narrow network a higher tier, and we can negotiate that because we have a larger a group of covered lives. We're investing more in the population health analytics, and because of those costs and because of those investments, we can drive down utilization and demonstrate a better return for the health plans. So we see a lot of things that are really driving organizations together.
And as you sit down and begin to talk about these product development, I mean, you start, I think, with more collaborative discussions through, contractually based joint operating committees or contract coordination committees where you just try to understand beyond the four corners of the document what the market looks like and where it's going. I think the narrow network issue is becoming obviously more prevalent. The exchange products heavily going into the narrow networks, and the creation of narrow networks, while they have price differential touch points, seem to be where the competitive alignment is going. As you do go into larger geographies, I think Kurt mentioned clinical integration, the Federal Trade Commission. We spent a lot of time thinking about, how close you can dance without touching, so to speak, in a way that the Federal Trade Commission would allow joint contractual negotiations among competitors, even those competitors whose overlap, is perhaps smaller across state lines, but still within any, quote, competitive market, end quote, would probably be seen as competitors. So one does have to pay a fair amount of attention on that score as well. Let me also just note for those attendees applying for credit need a number. I'll give you another number, RZQG, number RZQG. Kurt, let me come back to you and maybe ask a question. As your payer mix, or if your payer mix shifts with more proportionate or just more program patients, in particular Medicare, and commercial goes down, is that going to change how you go about managing the hospital?
Well, for sure. I mean, because the net revenue line is going to go down, and so yeah, for sure it will. So we'll probably have to. Right now we haven't done any of the models that our last speaker was suggesting with the bundling and that sort of thing. But as we exhaust our ability, and I hope we don't for a while, but as we exhaust our ability to squeeze out costs relative to the revenue stream through our workout methodology and the use of Lean Six Sigma, as that gets harder and harder to do, we're going to have to more fully engage the docs. For example, as it relates to implant costs. Well, right now they don't care. I mean, they don't want to. They're not particularly motivated to help us find a lower cost. I mean, they care a little bit, but maybe their relationship is stronger with that sales rep than it is with us. So, I mean, we've got to figure out ways to crack those kinds of nuts. So, yeah, absolutely.
Again, I invite anyone on the call to send in whatever questions they might have to our panel. And let me go back to Steve. I mean, there's a lot of talk about taking risk and how much risk you can take. How should an independent or one or two group hospital evaluate that question? How much risk can I take? Is there a benchmark, a recommended number? Well, what do you do?
Well, I think that there is, for one, I think that risk is a poorly understood word. We talk about risk in this generic way to refer to things that are not fee for service, and so we're seeing that organizations have a whole variety of ways that they can think about changing the way that they think through rate structure with a health plan. That does not necessarily just suggest that, boy, we're being capitated and we're taking capitated risk. And so we see a range of options from things like shared savings. So we're working on relationships now where we're negotiating contracts that say, boy, if we as a health system for this product, health plan product, for these defined population, if we can drive the medical loss ratio down to 85%, anything below that, we're going to share with the health system on a 50-50, or the health plan, a 50-50 basis or a 75-25 basis, such that we really are not taking a lot of downside risk, but we have an incredible incentive around not only rate, but also units of service. So as we see utilization declines and medical loss ratios go down, we as a health system can participate in that savings amount. So we're seeing organizations think about innovating the way that they compensate physicians, or innovate the way that they're relating to health plans to take advantage of some of these models that aren't necessarily going to impose a tremendous amount of risk. Because I think that as you get into it and you look at different alternatives, there's a range that your organization might be very, very comfortable with to say, boy, we could just change a few things here and do very, very well in terms of trying to manage care, manage utilization out of the system. And, if we're in a fee-for-service world, we have difficulties. And this is one of the things, Mark, just as an aside, we see a lot of organizations investing in things like patient-centered medical homes, and then at the same time, they're doing a very good job in terms of their PCMH strategy, and the CFO on the other side is looking at it and saying, yeah, but I want all of those patients to come to my ED to get an MRI because that's how I pay. And one of the dilemmas that we see health systems really face now is, how do we make sure that we have the right payment structure with the physicians, we have the right economic alignment with the health plan, such that we all feel good about being paid for doing the right thing instead of having these conflicting incentives among organizations that are within that one health system.
Steve, this is Ted. Let me just jump in. I'm sorry for dropping off there for a second. I was going through the mountains, but that should be cleared up now. You make a great point about the shared savings. And one of the big differences from a health plan or a payer perspective from where we tried this once in the mid-1990s to where we are today is that feeling of we're going to work our way through this together. We're going to go into the water one step at a time. And there are more shared savings programs across the country that I think anybody knows what to do with. How progressive they are, we can all debate. But from an insurance company, from a health plan point of view, those are step one. And what they're hoping to do with these shared savings programs is give people the opportunity to get used to it, to put some incentives in place. But let's all understand their game plan is the same game plan that CMS has, and that is moving folks towards some sort of very significant budgeted care. And as they evaluate whether or not you're a good partner for risk, they look at exactly the thing that you brought up, and what's the arrangement with the physicians. As Mark brought up, they are regulatory animals, and so they will either want to make sure that your arrangement meets their understanding of the regulations, or you have regulatory approval. And more they're going in and looking at those incentives, financial and otherwise, to make sure it meets their goals as well as yours. So, Steve, I bet you had some great comments there.
Thanks, Ted. As we look forward to this and explore other avenues and issues about being independent, sort of the overall size, everyone has said you need to be cognizant of your footprint. You need to be focused on the network. I haven't heard anybody say you need to acquire every physician in sight. Ted, your comments, people thought about that a lot in the 90s. They acquired a lot of people. They divested them. They acquired them again, divested them again. Not clear where all that's going. There's certainly a lot of that around. But larger footprint, need the network, need infrastructure at some level to both innovate and calculate. Calculate being how much risk can I take, in what fashion, and who can I partner with, all of which puts stress on the system as your competitors seek to do the same thing. And, on that note, let me kind of wind up today's comments. We appreciate everybody calling in. We'll be sending out notices in the near term about our next program, and I want to especially thank our speakers. So thanks, everybody, very much.
Thank you very much. Bye-bye.
Bye-bye.
Yes, thank you all.
That concludes today's presentation. Thank you for your participation.